The American Brain Tumor Association is pleased to welcome you back to our webinar series. My name is Umbreen Maan, Program Manager here at the ABTA, and I'm excited to introduce today's topic, Ependymoma Explained, Navigating Diagnosis, Treatment, and Survivorship. This webinar is presented in partnership with the Pediatric Brain Tumor Foundation, and we are honored to have Heather Held, Director of Family Support at the Pediatric Brain Tumor Foundation, here with us today to share a little bit more about their incredible mission and programs. Thank you so much, Heather. I'll turn it over to you.
Thank you, Umbreen, for the kind introduction, and to you and the team at the ABTA for asking us to join today for this important topic. We are really grateful to be here. A little bit about us. The Pediatric Brain Tumor Foundation was originally founded to support research for a cure, and over the years, we've really evolved to what you see and, more importantly, what you experience today. We not only stand at the forefront of funding childhood brain cancer research, but we support affected families and we advocate for policies that benefit patients, survivors, and their loved ones. Our cavalry of support for families continues to grow, focused on providing resources needed in every phase of this journey, from diagnosis to beyond. And we take special care to make sure we're inclusive of each family member, recognizing the need for the individual care. Our advocacy team works tirelessly to make sure that pediatric brain cancer is a national health priority. And finally, our research is not only just focused on a cure today, but on addressing the critical gaps in research and transforming the landscape. Next slide. As families come to meet us, either through hospitals, friends and family, finding us in a Google search, social media, or in partner webinars like this, our patient family team really strives to connect individually with each family. While we are a national organization, it's important to us that we maintain intentional connections and community and conversation with families. We want to spend time with you, learning about your child, where you are in the journey, and then offering appropriate educational, emotional, financial, and recently added medical stewardship support for the phase that you're in and the unique needs that you and your family may have. Our education includes a notebook for newly diagnosed families, a survivorship resource guidebook, monthly webinars with different subjects. We've grown our emotional support programming so that we not only have a robust peer mentor program with over 80 mentors, but we also have 11 active virtual support groups for siblings, bereaved families, newly diagnosed families, survivors, and native Spanish-speaking families. Financial support can be found through our emergency financial assistance program, the Butterfly Fund. And then recently, we're excited, we've partnered with Uber and are able to provide transportation and Uber Eats to families to provide a little bit of relief to you, the parents and caregivers, so you can focus on the medical decisions and care for the children. We strongly believe here at the PBTF that no family should walk this road alone, and that includes not just caring for you, but your child who has been diagnosed, your siblings, and your family. We want you to feel like you can depend on us and you're not alone when you join the community. I want to thank you all for joining today. I'm excited for the presentation, and if you want to learn more about the PBTF, you can visit us at curethekids.org, and ABTA will also be sharing some information about us after the webinar. Thank you, Umbreen. I'll turn it back to you.
Thank you so much, Heather, and thank you for taking time to share some of the wonderful resources at the Pediatric Brain Tumor Foundation. As Heather mentioned, we will be sending out a resource handout after the webinar, so please keep an eye out for that. It'll include additional resources from the Pediatric Brain Tumor Foundation as well. Now, without further ado, I would like to introduce today's presenter. Dr. Sturgios Zacharoulis is the Director of Pediatric Neuro-Oncology at Columbia University Medical Center in New York. He has led various clinical trials evaluating new agents and the development of a novel drug delivery program for children with brain tumors, focusing on convection-enhanced delivery and focused ultrasound. He is currently launching new clinical trials with novel medicines for pediatric brain tumors, including ependymoma. Dr. Zacharoulis' research interests include the utilization of advanced MRI imaging and imaging biomarkers to personalize radiotherapy for patients with malignant primary and metastatic brain tumors. Thank you so much for joining us, Dr. Zacharoulis. You may now begin your presentation.
Thank you so much, Abrin, and I would like to express my enormous gratitude to ABDA and to the Pediatric Brain Tumor Foundation for giving me this opportunity to update the public with what is currently happening in ependymoma. So next slide, please. So the plan for this presentation is primarily to provide an update on the current status of the treatment for ependymoma, the presentation, the epidemiology, and also to focus on the long-term follow-ups and the late effects and how this impact the patients and their families, and to try to make it as practical as possible, delineating the aspects of this journey and what are the future directions in this disease. Next slide, please. So I'll start with the epidemiology. The ependymomas are overall rare tumors. So just as an example of numbers, approximately 200 children and 1,100 adults per year will be diagnosed with this tumor. The overall incidence, and this is data from 2000 to 2010, it is always like this when we have epidemiological data, they're lagging behind, but we can see a slight only increase in the overall incidence. At the lower part of the slide, you can see the, as we call it, the pie of the distribution of the incidence of the various brain tumors. And as you can see, ependymoma is primarily a thin, very tiny portion of this pie depicted in red. And as we go through the ages, we have approximately 6% of the brain tumors in children, and then in adolescents is about the same, whereas in adult tumors is even much less, approximately 2%. Next slide, please. So first of all, what is ependymoma? And I think it's important to, when we think about the presentation and how this journey begins for the patient, let's take a step back and think about what is the actual tumor and where it originates from. In the past, we used to use the oversimplified term that ependymomas come from the ependymal cells of the brain, which in reality is not exactly accurate. Several groups have found years ago that in fact the cell of origin are the radial glial cells. These are part of the neural stem cells. So practically speaking, the very early primitive cells that are during the embryonic life are able to create the neurons, the cells that support the brain, the astrocytes, the glial cells, and also are the cells that dictate not only which cells are going to be formed, but also how they're distributed in the brain formation during the fetal life. Having said that, we need to keep in mind that these cells create a tumor, and as such, there are two ways to create symptoms within the brain. One is as they expand within the brain, occupying an area that is not supposed to be there. And the second being infiltrative, that going through the sensitive areas of the brain, affecting the neurons or the glial cells and creating symptoms. And when we think about ependymoma, there are three main categories. And the ones that are at the back of the brain, the posterior fossa, which typically will present with symptoms of headaches, ataxia as in unbalanced gait, difficulty walking, or even neck pain from irritation from the meninges, or the cranial nerves don't work properly. What does this mean? It means that the patient will present with asymmetry on the face or difficulty moving the eyes appropriately or crossed eyes. Or for the supratentorial ependymomas, which is the second type of location where we see these tumors, is supratentorial are the ones that are on the surface of the brain, on the top of the scalp. And as such, they have very different presentation, mainly with headaches, but also with seizures or some what we call focal neurological deficits and weaknesses. For example, not being able to move as much the arms or the legs or the sensation, or even personality changes. The spinal ependymomas are also different in terms of their presentation, and they can present with typically back pain or lower extremity weakness or difficulties with the sphincters, meaning the urination or defecation. So these are the main symptoms. It all depends on the location, of course, of where the lesion is, and the symptoms would be different. Next slide. So one very common question that we get is why? I mean, why did this happen? And as I alluded earlier, first of all, the blunt answer is unfortunately we still don't know, although there has been tremendous progress in the evaluation of the biology of these tumors, as we will speak a bit and talk about a bit later on. We haven't been able to identify the cause. What we know is that there is an initial event during the fetal life for reasons that we don't know. But there are subsequent signal changes within these neural stem cells that give rise to ependymomas. One thing that we definitely do in the beginning of the journey as we evaluate the patient that presented with the symptoms that I mentioned before is we ask very carefully about family history. And in general, most of the ependymomas, there is no significant family history with some exceptions. And this is the neurofibromatosis syndrome. This is typically for spinal cord ependymomas in adults, not as common in children in terms of the cause of ependymoma. And this is a syndrome where the patients will have other brain tumors such as meningiomas or primarily what we call acoustic schwannomas in the areas where they affect the hearing and some skin or eye lesions. And of course, there is the strong family history. One important syndrome to mention is what we call the Li-Fraumeni. This is a familiar cancer syndrome, and we always have an alert when we ask the families, and what we specifically ask is about cancers before the age of 45 in the family and the immediate family. And this is primarily for tumors such as sarcomas, breast cancer, leukemias, and other gliomas. It has to be said, though, that specifically for ependymomas, the association of ependymomas with Li-Fraumeni is weak from the point of view that it is not the most common tumor that the patient with Li-Fraumeni will develop. And P53 that is not as a strong driver as it is in other tumors. And there are some other rare tumors, as I mentioned here, like case reports for Turcot syndrome or multiple endocrine neoplasia. One interesting issue is about, there has been some literature in the past about a specific virus. This is a question that we are asked in clinic all the time about whether viruses, vaccines, etc. And there was a specific, definitely not vaccines, by the way. And in terms of the viruses, there were some early data to suggest that within the tumors, with the ependymoma tumors, that there were sequences in the genome that they imitated SV40 virus. And in some either animal models, the virus was able to contribute to the growth of ependymomas. However, Subsequent studies did not find any causality, so there is no clear association. So there are a lot of things that we obviously don't know. Next slide, please. So what do we, after the patient presents with the symptoms that we mentioned earlier, how do we reach the diagnosis? What are the next steps? The first step that we do is we do imaging. Sometimes we have to do an urgent CT scan, but the main imaging study that we still perform is the MRI. And there are various, based on the characteristics we are in the location, we're able to narrow down at least the differential diagnosis in the posterior fossa, at the back of the brain or in the front, with very characteristics, specific patterns of imaging that narrow down the differential to 2 or 3 tumors, including the ependymomas, and also the spine. As I will mention later on, the hope is based on artificial intelligence that we will get much more utility out of these MRIs in order to predict a lot of various things, as we'll discuss later. The other thing we do is a spinal tap. We have studied this quite a lot, and this is one of the brain tumors that tends to disseminate in the spine, thankfully not as frequently, and mainly at the time of relapse. But it is considered still part of the initial workup, where we do practically an evaluation of the spinal fluid to evaluate for circulating malignant cells. This is now, as up until now, however, as we move into the future, we are hoping that we will be able to detect the microscopic, further than the microscopic, at the minute level of levels of DNA that will be able to tell us whether there is a risk of dissemination based on what we call cell-free DNA. Next slide, please. So as I mentioned earlier, one of the major areas where we have made progress, unlike therapeutics, unfortunately, is the evaluation of the biology and the prognostication of tumors based on much more sophisticated evaluation of the tumors beyond the microscope. So starting again from the top all the way down to the spine, for the supratentorial ependymomas, in the past, we used to use only what we call a grade 2 or 3 ependymoma. This is not the case anymore. And as you can see, for the most recent classification 4 years ago, there are even the supratentorial tumors, the tumors that appear on the top of the brain. They can be subcategorized based on some expression of some specific markers, what we call the ZFTA fusion or the YAP1, and some chromosomal abnormalities. Between patients who have a better prognosis and less favorable prognosis, the YAP1 being the better prognosis to have. There are, however, there is a subgroup of these patients that don't belong to either. And this is approximately anywhere between 17 to 30% of the patients. When it comes to the posterior fossa, the back of the brain, we have subcategorized these tumors in posterior fossa A and B, B being the one with a better prognosis, which retains one of the H3 mutations that has to do with epigenetics, whereas the posterior fossa type A is the tumor that is also associated sometimes, not always, thankfully, with a chromosomal abnormality called 1q gain, where there is a little piece of a chromosome that is being gained within the tumor. And this is associated, unfortunately, with poorer prognosis, still curable, but less favorable in posterior fossa B. And finally, the spinal ependymomas. These days, we know that MYC amplification, a specific gene that if we find in genomic evaluation of the tumor, makes a big difference. because if the gene is amplified, meaning it is multiplied in different copies, this implies a very poor prognosis, and we have to find better treatments. So this has been based on the excellent science from our neuropathologists, biologists, and translational physician scientists, has been extremely helpful to identify these molecular predictors. Next slide, please. So the patient arrived, we had the presentation, we did the MRI, we sent the sample to the pathologist, we have the molecular pathology back, and then it's time for treatment, after we have also the spinal tap results. So what are the basic principles of treatment for ependymoma? By far, the most important aspect of treatment and prognosis for ependymoma is surgery, as it might seem obvious, but in our case with ependymoma is even more important. This is a graph that depicts the difference between progression-free survival, meaning the time until the tumor comes back, if and when it comes back. And as you can see between the two lines, in the top one is the excellent outcome of patients who have what we call a gross totally resected tumor, meaning that the very, very vast majority of the tumor has been removed with only a millimeter or so left behind, depending on the definitions, or ideally with no visible tumor, versus what we call subtotally resected, when there is still quite a lot of visible residual tumor. Why this is important, and what is the practical takeaway message from this? And I've had the privilege to work both in Europe and United States, and there is a great variability in terms of expertise in various hospitals and institutions. Ependymoma is a neurosurgical disease, and because of that, it needs to be taken care in institutions where especially the neurosurgeons have expertise and experience. The reason being because of this graph, that without a gross total resection, when technically feasible in experienced hands, this has significant impact in the outcome. So this is not a surgery that can be done in a hospital where ependymomas are not seen, or a hospital that has only pediatric, or even a neurosurgeon who never operates in the posterior fossa. So there are tertiary care centers that need to be deal with this type of diseases. Next slide, please. The second most important aspect of the treatment for newly diagnosed patients is the radiation therapy. So it's considered now a standard, and I will talk a little bit about a few exceptions, etc. After the surgery, we give radiation therapy with doses of 54 to up to 59.4 gray. In the past, there were some studies where the whole axis, as we say, meaning both the brain and the spine, would be irradiated. We know now that this is not, there's no reason to do that for local tumors unless the tumor has spread to the spine. And the age in which there is the lowest limit for use of radiation therapy has been proposed to go as down as to 1 year of age, especially for almost exclusively, I should say, for what we call the posterior fossa tumors, the back of the brain. This was Dr. Merson, a pioneer study, that the initial study that brought the age cutoff limit down to 1 year. Globally, as it stands, 3 years is the accepted lower limit, depending on the country, the institution, etc. There are preferences for the infants, but it is considered acceptable to irradiate now a baby with a young child 1 year and older for a posterior fossa tumor. Next slide, please. So a lot of times the question is, okay, radiation, but what type of radiation and how? On the right-hand side, I just have a simplified version of the difference between the conventional radiotherapy, which uses photons, versus the proton radiation therapy. The difference between the two relies on to how the energy is delivered within the brain. With the conventional radiotherapy, the energy is being released starting all the way from the entry point throughout the brain without any modifications, except when it is being given with specific techniques like IMRT, whereas the proton itself, the beam itself, the energy gradually is released specifically at the points that is intended to, as the radiation oncologist together with the medical physicists make their planning. So what are the advantages of the protons, at least theoretically? That spares the tissues that we don't want to be irradiated so that we don't affect the healthy brain in terms of neurocognition, endocrine deficits, etc. But what is the evidence so far? First of all, we do not have randomized studies. Randomized as in comparing prospectively, as we say, half the patients to get more modern photon therapy versus proton radiation therapy, because logistically it's very difficult. But we do have comparisons with historical controls. And for example, a study by our colleague, Dr. Indelicato, showed that at least from the efficacy point of view, in terms of the proton radiation therapy, there is no significant difference in terms of the outcome, in terms of control of the tumor. And when it comes to toxicity, there is evidence that the hearing loss, the hormone deficit, the vasculopathy is probably a bit less than what it is with conventional radiation therapy. But again, this is not a randomized study. One thing to mention is that I remember maybe 15 years ago, or maybe a little less than that, initially when young babies with ependymoma of the posterior fossa were irradiated with protons, there was some slight concern about brainstem toxicity. Thankfully, this remained at very low levels in terms of the incidence, so is not considered any major issue, but the colleagues, radiation oncologists, are always alert with this issue about very young children. But in general, the recommendation is to, if the proton center is available close by where the patient and the family lives, to be prioritized. But again, there are no randomized studies to say that the modern photon radiation therapy, like IMRTs, etc., intense modulated radiotherapy, or conformal radiotherapy is necessarily inferior. Next slide, please. So how about the patterns of relapse for patients who get irradiated, and what happens with the second tumors? So as we said earlier, one of the issues when we give radiation therapy is that we irradiate the healthy tissue, and this of course causes damage to the DNA, and this predisposes patients to other cancers. Thankfully, when we look at the data with protons, the cumulative incidence of second cancers after radiation remains very low. I mean, it's not zero, but is not very high. It's about 3.4%. And when we look at the failures, as we say, of the radiation, meaning where the tumor comes back, if it comes back and when it comes back, we can see that by far the most common type of recurrence is local, meaning at the same place where the original tumor presented, whereas less commonly but existing is the distant failures. Distant meaning in other parts of the brain or the spine, separate from the location where the initial presentation was. Next slide, please. So the natural question when we discuss with families about the potential long-term side effects of the toxicities of radiation, which I will mention a little bit more in detail later on, is can we avoid the radiation therapy in some instances? The overall, the recommendation is that most of the patients with ependymoma do need radiation therapy. However, there are some exceptions that can be considered, especially in what we call the supratentorial ependymomas. Again, the higher up in the brain tumors, especially the one that I showed earlier with the YAP1 positivity, which makes the patients having better prognosis overall. And when we look at the data, unfortunately, with very small number of patients, the patients who had the gross total resection, meaning minimal residual tumor after the surgery in this location, who for some reasons, either because of very young age or refusal from the parents, they did not, or because the surgeon or the oncologist elected to do so, the conclusion is that most of the patients are either do not relapse, or if they do, are salvageable, as we say, with the radiation for the vast majority. But again, the problem is this very small number of patients, and everybody in every trial, the conclusion is that we are very hesitant to make a clear recommendation. And some, even the SEER data study that combined adult and pediatric studies, showed similar things in terms of no significant outcome differences in patients who received radiation therapy if they had the gross total resection. So the same applies for adults. When it comes to the posterior fossa, the back of the brain, again, it is only the subgroup of the beta subgroup with a better prognosis that maybe there is a suggestion that radiation is not needed, but the consensus amongst us, the colleagues in the community, the pediatric neuro-oncology and adult neuro-oncology community, is that the radiation sparing strategies should be tested in clinical trials so that we don't jeopardize the overall the survival. And I will mention some exceptions for the adults as well. Next slide, please. So that was the radiation therapy, and now even more controversial about chemotherapy. So chemotherapy has very limited role in ependymoma, and we're still trying to identify where chemotherapy fits into this whole journey. And there have been numerous trials among the years to clarify this question. But one thing that we all have accepted is perhaps that chemotherapy can help achieving what we call a CR, like a complete response, not to have any visible tumor prior to irradiation, because we know that if you do have that, either because of surgery or surgery plus chemotherapy plus second surgery, the outcome is better. So that's one, the indication. The second, which I will talk a little bit more in detail in the next slides, will be about the infants. Not to confuse you, I did mention earlier that the cutoff for radiation has gone down to even 1 year of age, at least in the United States. However, if there is an infant with a large supratentorial tumor in the cortex of the brain, it will be very difficult to advise for radiation therapy in a very young infant, although sometimes, most of the times we end up doing it, but we do pay the price of the neurocognitive deficits. Therefore, this is a very rare situation where alternatives will be needed. And this is where chemotherapy has been used in the past. And there is a maintenance chemotherapy question, meaning you gave your best treatment, surgery and radiation. What is the benefit of continuing for these high-risk patients, the ones that have adverse biological factors, to have chemotherapy versus not? And the study was completed by Children's Oncology Group, my colleague, Dr. Amy Smith. This data are going to be published very soon. Again, it's not very clear, though, that the chemotherapy has an effect. But going back to the infants, next slide, please. There have been various studies in both in Europe and in the US and other countries that attempted to spare the radiation by using chemotherapy. The chemotherapy includes conventional agents like the increasing carboplatin in the UK with methotrexate, in the United States without, but a different regimen, similar in regimen, but with some differences, the timing of the radiation. Some studies will have the radiation only the time of progression, or until you reach the age of 3, etc. But the key issue is here on the left side in the table. What is the radiation-free survival that we achieve? And you can see even from the UK and from the American study, it's very similar, approximately 40%. That's suboptimal. And then you can see the graph here, the impact of the radiation and the timing of radiation. So verifying again that unfortunately radiation is a very important aspect in terms of the cure. Next slide, please. We, with Dr. Finley, we published the data for high-dose chemotherapy. So instead of giving very long chemotherapy to try to avoid radiation, whether we can give even autologous bone marrow transplant, highly toxic therapy, for patients with ependymoma. So although in this small study we saw very good responses with a very intense regimen before the transplant, we were not able to show that the high-dose chemotherapy with stem cell rescue, the autologous bone marrow transplant, can provide a radiation, meaningful radiation-free survival. As you can see, it's very low. So this has been unfortunately not successful as an attempt to delay or avoid radiation therapy. Next slide, please. So what happens? What can we do about ependymoma when it comes back? So first of all, how do we identify the recurrence? So a lot of times the families, when we see them and they have completed therapy, they have a different type of stress. The type of stress will say, okay, we are done now. We went through the stress of the treatment, but now we are on a waiting game. This is where ependymoma is very unique. It is the problem with ependymoma is that, and this is where psychologically the families need to be prepared and need to have the appropriate support, is that unfortunately the follow-up has to be very long. The reason being that the ependymoma can recur even at late stage, many years after the end of therapy. What we have found is that, first of all, the MRIs are important. And as I will mention again earlier, it's important not to be missing our scans, because a lot of times we will detect the recurrences before symptoms occur. That's one thing. And the second is, as I mentioned earlier, most of the recurrences, it's more common for the recurrences to happen locally, meaning to the same place where the tumor originated. And this means that in terms of how the patient will feel, it probably might not feel anything at all because the recurrences are small and you will detect them with the MRI, or might have similar symptoms to the ones at the time of presentation. If, however, the recurrence is, as I mentioned earlier, distal, meaning in other parts of the brain or the spine, then we go back to the initial presentation where, depending on the location, we might have different symptoms. As I mentioned, we monitor for back pain, for personality changes with headache, seizures, vomiting, cranial nerve deficits, strabismus, like crossing of the eyes, in general, neurological deficits. Now, unfortunately, these are some data that we had collected many years ago, and the reality is that they have not changed significantly, that the prognosis remains poor after if the tumor comes back. That's why it's very important to have the appropriate best possible therapy in the beginning. Is not that it is impossible to cure, but it is difficult. That's the reality. And how we approach it, we go through the order of the importance of the various treatment modalities we mentioned earlier. One is the surgery again. Re-radiation is probably the most important part of the treatment after surgery again. Whereas with the chemotherapy, we have seen responses, but unfortunately are transient, and eventually we need to enroll in what we call phase 1 trials or other experimental therapies. One out of these chemotherapies, the one that stands out is what we call metronomic chemotherapy, which is low doses of chemotherapy by mouth with various combinations that is very well tolerated, and in some subgroup of patients have led to significant prolongation of controlling the disease. And this is an area that we probably can look at more carefully as a backbone to build upon, because alone maybe is not enough in but vast majority of the patients. Next slide, please. So I mentioned the re-radiation aspect. I'll just give you an example of how the pattern of relapse, for example, as I said, if it is local versus distant, local in the same area or in other areas of the brain or the spine, has a significant prognostic impact. And remember, I mentioned the chromosomal changes that we evaluated at the time of diagnosis. It seems that they do have a prognostic significance even at the time of relapse. So in general, as you can see, the distant only failure, meaning only in areas that are new, different from the initial local disease, are giving us a better chance of overall survival and cure from the disease despite the progression. Next slide, please. So I mentioned earlier that there are some differences in adults and pediatrics. First of all, the adult tumors are more common in the spine, the ependymomas, whereas in children are more frequently in the brain, less in the spine. What we call grade 3, what we used to call them anaplastic, are more common in children. And this adverse biological factor in terms of the chromosome 1q is only slightly more frequent in children, and the type A posterior fossa that we mentioned earlier is merely exclusive to children. Next slide, please. So, and in terms of the differences in the approach, the surgery remains, again, the most important aspect of the treatment and is still prognostic in adults. The clear indications for radiotherapy are for the grade 3 tumors or incompletely resected. And here there is definitely no role for chemotherapy. There have been numerous trials with various chemotherapy combinations or other agents that unfortunately have not led to any significant change in the standard of care. And the spinal tumors, the main one to mention is the myxopapillary ependymoma, which we see in pediatrics, also in adolescents and young adults. They are very interesting tumors that even if they are metastatic, still the patients do very well. The timing of radiation is a bit more controversial, meaning that you probably could afford to irradiate a bit later on. For the recurrent tumors, again, re-radiation plays a major role also, as it does for pediatrics. Next slide, please. So how do we approach let's say we did the re-radiation, the patient has progressed, then the standard approach to a patient who has multiple recurrences, and after they have exhausted the re-radiation potential or surgeries, is to consider experimental therapies. And we look for new targets. This is one of the examples where you might see here in the ependymoma from a study from Dana-Farber, where HER2, this is a target that families probably might be aware from patients with breast cancer, where this has been be targeted with novel agents such as trastuzumab, which is a monoclonal antibody against this receptor and driver with very good promising results. And this now is being investigated. Primarily, Dr. Foreman has been leading trials on this and has done extensive preclinical work. And the trials are ongoing. It will be interesting to see how this evolves. Next slide, please. So, Dr. Donson, working on brain tumors for identifying new agents, has provided us with some clues about potential classes of new drugs, but some of them are already on trials. For example, the fluorinated pyrimidines, like the 5-FU or new generation of those, or some new tyrosine kinase inhibitor like axitinib, for example, is being evaluated now in combination with the toposide in Europe. These are ongoing studies. For those who are interested, I would highly encourage to visit the clinicaltrial.gov, because this trial is closed and open by the minute, so it's important to have direct access. Next slide, please. And of course, CAR T cells. CAR T, what is CAR T? The CAR Ts are the chimeric antigen receptors, where we take T cells from the patient and we modify them biologically so that they are able to attack the tumor. There have been preclinical data with that to justify its use, showing some efficacy, and this is the CAR Ts are being investigated right now in clinical trials in both in Europe and United States for targets like the EGFR, the HER2, and the B7H3. Next slide, please. I want to emphasize the long-term follow-up aspects. So we mentioned earlier, we keep mentioning radiation, surgery, etc. But what the patient and the family should expect long-term, and what are the risks? As you can see here, this is an example of one of the studies, but there are many others. that we need to keep in mind, and this is what when we see patients long-term after the completion of the treatment, that the patients are at risk for an increased risk in comparison to the general population for stroke, for second cancers, and I mentioned thankfully less commonly, hearing deficits and disability, depending where the tumor is, whether there was hydrocephalus, meaning buildup of the fluid. Thankfully, this data that look a bit worse than what we expect to be in 5-10 years from now, because this data come from older techniques of radiation with some mixed bag of some of the patients having received protons. But this is very important to keep in mind, because the general practitioners, the primary healthcare providers, they need to be part of this journey and have this in mind, and education will be very important. Next slide, please. The other aspect is we need to make sure, and I want to make it a very strong point here, is that we have to make sure that, especially for children, that we do follow their neurocognitive status for years, because unfortunately, this can start declining even further than 5 years. And as you can see here these are the overall the IQ for 10, 15 years. This is the processing speed, the perceptual reasoning, the working memory, and the verbal comprehension. These are functions, neurocognitive functions, that, as you can see, in some patients, not all of, obviously, it can be very lately affected. Next slide, please. And this is so what we do. It's interesting, the studies have shown that MRI imaging for surveillance is even more important, as you see, than the symptoms, more important as from the point of view of picking up recurrences. Is not more important, is more common to pick recurrences earlier than the symptoms. So that's why please don't miss, for patients, families, if they do not miss your MRIs, and we shouldn't be falsely reassured, even if it is 2 years. This frequency that we all have accepted is every 3 to 4 months for 2 years, and every 6 months for 5 years, and annually after that. Next slide, please. So, Dr. Wang, my colleague, had written a very nice paper with his colleagues as well about the obstacles in the making progress. So as you see, a lot of the references that I have are from 10 years, etc. Nothing has changed. Well, one of the biggest problems is that we don't have good models for ependymoma. Models as in animal models or neurospheres, etc., that they can predict what happens in humans. And even despite the progress in the biology and the prognostication, unfortunately, most of the genes or proteins that we have found, they are not targetable easily. That's why we haven't discovered new drugs. However, I depict here some of the classes of agents that are being investigated preclinically, and hopefully some of them will come on trials. For example, HDAC inhibitors already have been evaluated and being evaluated even for infants in Europe with chemotherapy, and some other BET inhibitors. The MAT2A inhibitors are very exciting. They're being investigated in adults. So, but more importantly, I would say that the novel radiation approaches that are being investigated right now, like what we call flash radiation, or that are supposed to be safer, will be very important. Next slide, please. And of course, we're waiting anxiously for the artificial intelligence to help us. More and more studies are coming, mainly from glioblastomas, and as I mentioned here on the right side, that we will be able to start predicting by using the MRI the feasibility of the gross total resection, what is the biological profile without waiting for the tissue, how we monitor the tumor response in a better way, and what is the predicted functional outcome, so that we provide even more vigorous support. Next slide, please. So in conclusion, ependymoma is a chronic, heterogeneous, rare disease, meaning that every patient is different. And I hope that this curves with survivors, etc., do not scare families who are attending this, because every patient, as I said, is different. There are a lot of exciting things that are happening in terms of research. Surgery and radiation are considered standard, but we need to keep in mind that the late relapses can occur. The novel therapies are desperately needed, but I think the speed by which we have evaluated biology will help us accelerate the discovery of new drugs. And very, very important not to forget that the psychosocial impact and how much support these families need long-term in terms of the neurocognition, the disabilities, and the other risks. And with that, I will thank you all for your patience and attention.
Thank you so much for your presentation, Dr. Zacharoulis. We do have some time for questions. Just as a reminder, if you do have a question that you want to ask, please type and submit it using the Q&A button, and we'll get through as many as we can in the time that's remaining. So one of the first questions we have here, Dr. Zacharoulis, is from an adult ependymoma patient, middle-aged male, and he would like to know, can you share some information about the average time until recurrence from when a patient has completed treatment? This particular person, he says that he is 19 months post-surgery.
And where was the tumor? I'm sorry.
It was extraventricular.
I see. Okay. Yes. So for all depends. For an extraventricular tumor that I assume that was probably grossly, totally resected, the expected outcome is excellent. Because these are amenable to a very good resection. So in the minority of patients where this can come back, the highest risk is within the next 2 years from the time of the surgery.
Thank you so much. We have a question here. This individual, her daughter, was just recently diagnosed with an ependymoma. She's 8 years old and an identical twin. Is there any concern that this mother should have for her daughter's twin sister? Is there any potential that she might be predisposed to an ependymoma? Yeah.
There are case reports of familial ependymoma, literally case reports, meaning that it is extremely, extremely rare. However, it's important to have a proper family history and a genetic evaluation. But in general, no, there is no need for immediate evaluation by MRIs, etc. But a genetic workup, it might be worthwhile depending on the family history.
Thank you so much. Another question we have here is asking, you mentioned the importance of finding a treatment center that sees ependymomas, especially for better outcomes surgically. Can you provide any advice to patients on how they can find treatment centers like that? What are some questions they should be asking to make sure that their surgical team can handle this?
Yes, that's a great question. I think the only, first of all, I hope and I assume that the colleagues who see these patients will have the knowledge to refer the patients, so the families don't need to ask for it. But in case they need to, the question that we need to ask to the oncologist who see the patients or to the primary physician who made the diagnosis or the surgeon to say that we would like to be evaluated in what we call a tertiary pediatric or adult oncology center. Tertiary as specialty center for referrals. And depending on the location, this is something that the colleagues in the community are able to advise accordingly the family.
Thank you so much. I'll also share that the ABTA does have a brain tumor treatment center guide that can help patients and families find treatment centers that are appropriate for them. Unfortunately, that is all the time that we have for questions for this webinar. For any unaddressed questions, we'd be happy to help address those post-webinar. But thank you again, Dr. Zacharoulis, for your time, for sharing your expertise, and for taking the time to address some of the questions here today. I also want to thank the Pediatric Brain Tumor Foundation for their support in developing this webinar and helping put this together. And finally, a special thank you to each and every one of our attendees here with us today for joining us and for sharing your questions.
Thank you so much.
We do encourage you to please take a few minutes to complete our webinar survey by scanning the QR code on your smartphone or going to the link on the screen. Your feedback is important to us as we plan for future programs. You'll also be receiving a link to complete the survey, along with the webinar recording and our resource handout in a follow-up email message in the next few days. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282. For more information about the Pediatric Brain Tumor Foundation, visit curethekids.org, call 1-800-253-6530, or email info@curethekids.org. This now concludes our webinar. Thank you again so much for joining us, and enjoy the rest of your day.